Okay, you guys, I'm going to go ahead and start because I think people are trickling in. So good morning, everybody. My name is Yo-Yo Zhang. I'm an advanced transplant hepatology fellow. I'm also a member of the Grand Rounds Committee. It is my great pleasure to welcome you to Grand Rounds this morning, and even greater pleasure to welcome the speaker today, Dr. Lee Trope, who I had the supreme benefit of training here at Stanford with in our PEDS residency, and someone who I just admire wholeheartedly. A few housekeeping details. Take a moment to take note of the text code that's on the left side of your screen to get CME credit. And then please use the Q&A feature to ask any questions that you have. The chat will actually be off, and so all questions can be directed through the Q&A feature. Next week, to mention next week's Grand Rounds and upcoming topics, next week's Grand Rounds will be given by Dr. Tanya Gruber. She's the chief of our Hemonc and Stem Cell Division here. She's an incredibly accomplished physician scientist. She will be speaking on research frontiers in pediatric acute myeloid leukemia. And it should be a fantastic talk. The following week, we're welcoming Dr. Hal Dietz. He's a professor of genetics at Johns Hopkins University. He's one of the sort of leading authorities on Marfan syndrome. He'll be coming on January 14th, and he's going to speak on disease modifiers of Marfan syndrome and related aneurysm conditions. So that should be a real treat. I'd also like to take this opportunity to advertise our upcoming pediatric research retreat. And so this is a wonderful opportunity for physicians and physician scientists at all levels, especially trainees, to disseminate their work among our community and then create new research relationships too. So please consider submitting. And then lastly, please save the date for an upcoming live webinar. It's given jointly by our Stanford OB/GYN department, the Johnson Center for Pregnancy and Newborn Services, and in collaboration with the MCC POP, Mid-Coastal California Perinatal Outreach Program. It's a webinar series that covers sort of a potpourri of high-yield perinatal topics. For more information, scan the QR code or check out the MCC POP website. So without further ado, here are my favorite chief residents, Janji Barber and Elisa Phillips, to introduce our speaker today.
All right, hi everybody, I'm Janji, I'm one of the chiefs here.
I'm Elisa, I'm another one of the chiefs.
And it's truly an honor for us to welcome back Dr. Lee Abby Trope as a presenter at Pediatric Grand Rounds, now going on round 2 for presenting. Dr. Trope trained in pediatrics at our very own Lucile Packard Children's Hospital, where she was known for her brilliance as a clinician, her tireless work as a child advocate, and her unwavering collegiality. Dr. Trope served Stanford Pediatrics for an additional year as a chief resident, our chief, as we were in her intern class. Her legacy as a chief includes the creation of academic half-days, which are now an established part of our curriculum, as well as the promotion of trainee autonomy, including the creation of independent rounding, a resident favorite. Dr. Trope's work on resident autonomy was recently published in academic medicine, and many programs across the country are now adopting this intervention. Beyond that, her legacy at Stanford is also one of leadership, passion for learning, and friendship, and the tone she set still reverberates throughout the residency to this day.
Since finishing her chief year, Dr. Trope has worked as a pediatric hospitalist at Santa Clara Valley Medical Center, where she continues to mentor trainees of all levels and even won the very coveted Golden Apple Teaching Award in 2020. Additionally, Dr. Trope is the director of the Santa Clara Valley Medical Center Adolescent Inpatient Buprenorphine Program, and in 2021, she secured a grant through the California Residency Program Collaborative to train our pediatric residents how to manage opiate use disorder in adolescents. We are so thankful to have her here today to share her experience with this life-saving program. And with that, we'll hand it over to our forever chief, Dr. Lee Trope.
Thank you so much for the introduction. And though it's virtual, it's really nice to be back at Stanford. And I'm really looking forward to talking to you all today about my work on buprenorphine for adolescents at Santa Clara Valley Medical Center. I wanted to preface this talk just by saying, I'm not exactly sure who's in the audience. I can't see you guys. And I just wanted to preface this talk by saying I'm not an addiction medicine specialist. And I actually think that's really important. As you'll come to learn throughout my talk, this problem is huge And it's going to take more than just the addiction medicine world to be able to tackle it. And so I'm coming at this with a sort of a novice approach. I've learned very quickly on how to treat this disease, opioid use disorder. And I welcome any comments or feedback from any expertise in the room. But I also want it to be an inspiring tale for those of you who want to get involved, because even a generalist like me has been able to do so. I have no disclosures. So my objectives today are for everyone to understand the magnitude of the opioid epidemic and kind of how we got here, to describe how buprenorphine works and how it can help adolescent patients with opiate use disorder, and then to detail our new buprenorphine program at Valley. So we'll start. I know many people probably know this, but the opioid epidemic is worsening. We've been hearing about it for the last decade or more, and you'd think that maybe we'd made a dent in it, but actually 2020 was the worst year yet for overdose deaths. If you look at the figure that I have here to the right, you can see that the sort of on the left-hand side, there's a notch for the peak car crash deaths in our country, which was in 1972, and the peak gun deaths in our country, which was in 2017. And if you combine those two, we still don't get to the number of people that died from drug overdoses in 2020. It's a huge problem. There's actually 10 times more opiate overdose deaths than there were in 1999. And San Francisco, where I'm sitting right now, has in 2020 had 3 times the number of opioid overdose deaths than COVID deaths. So the city, just like the rest of the world, really changed society over COVID. And actually, we had 3 times more overdose deaths. Part of that is how well San Francisco did with COVID, but I think it's striking nonetheless. Now, I made that slide, and then I had to add this slide because when the news came out very recently that if you take the 12 months ending in April 2021, we got more than 100,000, an absolute record of Americans died from drug overdoses. And what you can see if you look to the figure on the left is that the vast majority of those deaths were from opioids, and the vast majority of the opioid deaths and the deaths overall were from synthetic opioids, really fentanyl. And we're going to talk about fentanyl a lot in this presentation. And this is very much an American problem. So when you look to the figure on the right, you can see that per capita, our death rate from drug overdose is an anomaly when you compare us to other countries. So how did this happen? It's a long and difficult story. It's been well documented in the medical literature, in journalism, and documentaries, but it's a very, very important story. So in broad strokes, I'll talk about a little bit what happened. So, basically access to opioids in this country dramatically increased in the 90s. And it had a lot to do with legally prescribed OxyContin. So OxyContin came out in the 90s. It was a sustained release oxycodone. So it was really marketed by Purdue Pharma because it was sustained release. It wouldn't have the peaks and valleys of other opioids. And therefore they argued it would be less addictive. They actually got the FDA to approve in the beginning a very highly unusual label that said that it was possible that it could reduce the abuse liability because of this sustained release. And actually, the person that approved that label ended up working for Purdue Pharma a few years later. So that label went with their pharma reps all over the country, particularly to rural areas on the East Coast, and convinced a lot of physicians that this really was a safer drug. But probably the biggest change that happened was through their marketing efforts and other efforts, there was a huge change in the way that opioids were thought about. So before OxyContin, doctors were many of you may have practiced during this time, doctors were pretty reluctant to prescribe unless there was severe pain or cancer-related pain. And there was a real big shift to treat more moderate pain or other types of pain with opioids. And a big part of that was this idea that pain was now a 5th vital sign. So before, pain was considered to be a part of the healing process. Suffering was part of healing. And then there was this culture that actually we need to be treated. As a consequence, opioids flooded the American market. So by 2012, there was more than 1 prescription per adult per year of opioids in this country. And again, the initial states that were really targeted were some of these rural East Coast regions. And already by 2000, there was some abuse and diversion news that began surfacing. And I brought in some of these statistics because they were just so striking to me. By 2000, Kentucky had seen a 500% increase in patients entering methadone treatment, and 75% of them were OxyContin dependent. In Maine, there was a 460% increase in patients seeking treatment for opioid use disorder and 400% increase in chronic hep C cases. And Virginia saw an 830% increase in death related to opioid prescriptions. So really striking. And if you can see the figure on the right, once again, a very American problem. So it's the standard daily dose of opioids per million inhabitants. And you can see clearly that United States on the bottom there is quite the outlier in terms of how many opioids are prescribed. So, the first wave, there's considered now to be 3 waves of the opioid epidemic. The first wave was really defined by these prescription medications, really led by OxyContin, but the other opioids kind of were also prescribed a lot more during that time. Then what started to happen is around 2010, even a little bit before, the news of this diversion came out, a black box label was put on OxyContin, and physicians really stopped prescribing as readily. But the stopping of prescribing didn't concur with an increase in treatment services. And so the next wave really was the heroin wave. People who were already using were not finding prescriptions as easily, and they would move to heroin, which is actually much cheaper and much more potent, but also more deadly. And now here we are in wave 3. This is the deadliest wave. It's kind of known as the fentanyl wave. Around 2013, fentanyl started entering the market, and it was widely, accepted by those who are selling because it's much more easy to manufacture. It doesn't need to be grown. It can be made in a lab. And it's much more easy to transport because it doesn't have an odor, and you can fit a lot of it in a truck. I mean, a lot of it probably can kill the whole Bay Area. So it's much more easy to sort of get around. And of course, it's much more deadly. So fentanyl, many of you may know, is actually being increasingly added to cocaine, ecstasy, benzos on the street to enhance their potency. And we're having some fentanyl overdose deaths for people who didn't even know they were using opioids. Fentanyl is incredibly potent. I thought this visual was very telling. So if you think of morphine as the standard opioid dose, you can see that oxycodone is about 1.5 times stronger. Heroin is 2 to 5 times stronger, depending on how it's made. And then fentanyl, 50 to 100 times stronger. So incredibly potent and incredibly deadly, which is why we're seeing so many more deaths. Adolescents are also affected. So the opioid epidemic is not just an adult problem. These statistics were interesting to me. In 2019, there were 1 in 7 students that reported misusing prescription opioids, and 1 in 14 in the past 14 days. So if you translate that to our state, that would be about 314,000 12 to 17-year-olds. The reason why I'm doing this work, the real reason why we started doing this, is because already in 9 months into 2020, we had 17 overdose deaths in kids under 19 in our county. Much more than COVID. So 17 overdose deaths. That's incredibly high for our county, and kind of highlights the problem. And then, as you can imagine, in general, teens have a particularly rapid escalation in opioid use severity, high risk for overdose due to their impulsivity. And our experience has been, as it shows in the literature, that often have a poor insight into their disease process and how dangerous it is. And then this Pediatric Review article in 2019 came out, which was quite striking, that only 8.5% of teens with opioid use disorder have access to addiction treatment. In the adult population, it's about 20%. So we still have a long way to go there, but for pediatrics, there's really a dearth of options. So let's talk about medication for opioid use disorder. And we're going to specifically talk about the options and focus on buprenorphine in this talk. But I thought this was a nice graphic to kind of explain why people need medications for opioid use disorder. And I think there's medications for other addictions and other substances, but people seem to have some more success, for example, with alcohol use disorder, with going to rehabilitation facilities and not always needing, it's less common that people need medication, although some and many do. With opioids, it's some people are able to, get off of opioids without medication, but it's very, very hard. It's a lot more treatment resistant. And the reason why is kind of has to do with the pharmacology of opioids. So, people start taking opioids and they go from a state of feeling, let's call it normal, to euphoric. They feel connection, they feel love. Obviously, they're binding to our endogenous opioid receptors. And over time, they'll need to take more and more opioids to get to that same degree of euphoria. So if you kind of move towards the right, you can see that the peaks of euphoria are getting less and less. And then at some point, people think it's usually around 3 weeks of use or more, you start to have this tolerance or physical dependence. And what people describe is that they're not actually using anymore to feel euphoria. They're using to feel normal, because when they don't use, they go into this state of withdrawal, which is so uncomfortable. People feel like they're dying, and then they use just to feel normal. What opioid agonist therapy, what these medications do, is they keep people in that sort of normal range, not euphoric and not withdrawing. So they're able to go to school, they're able to go to work. And that's kind of one of the reasons why the medications really help in this disease. So medication for opioid use disorder really does save lives. In this graph, you can see the death rate for the general population, what happens if you have OUD, but you're not in treatment, and then if you're on medication, it significantly reduces your chance of death. Still higher than the general population, but much lower than no treatment. So what are the medications available for opioid use disorder? Far and away, I'm going to focus on buprenorphine in this talk, but I'll talk briefly about the two other options, which are methadone and naltrexone. Methadone, I'm sure many of you guys have heard of, know a lot about. I won't spend a lot of time on it because my experience is that it's nearly impossible to get for teens. Because it's a full opioid agonist, it's very highly regulated by the federal government, and you need to fail treatment and you need to have the disease for over a year. And there's all sorts of regulations to be able to get methadone. So very hard to get for teens. It works, it's very well studied, and it works well, but it can, because it's a full agonist, you have to go to a clinic each day to take it, which can be quite inconvenient for people. And again, it's very challenging to get for our teen population. The other option out there, less well studied, is naltrexone. Naltrexone is an opioid antagonist. It's also known as Vivitrol, and people take it for alcohol use disorder as well. What it does, is it blocks opioid and alcohol cravings and can stop people from feeling high if they were to use, because their receptors are blocked by the antagonist. It's just a shot, so it's not something that people have to remember to take every day. And really the biggest benefit of it, in my opinion, is that unfortunately, and we'll talk a little bit more about this, there's a lot of stigma for the opioid agonists like buprenorphine and methadone. And some, groups, treatment facilities, Narcotics Anonymous groups, people don't accept people who are on opioid agonists because they believe that it's also just using opioids. And so naltrexone is a medication that a lot of these programs will accept because it's not an opioid in and of itself. The reason why I haven't been that excited about it, A, it's not as well studied, but B, if you are on naltrexone for a while and then you relapse, you've lost your tolerance. And so there's still a high risk of overdose. And so I've been a little bit reluctant. We've been a little bit reluctant to use it in our teen population, but as the literature comes out, that may change. Of course, the best practice is to use medications in combination with counseling and behavioral therapies, and we'll talk more about that in a little bit. So let's talk about buprenorphine, because that's the medication we're using at Valley, and it's an incredibly interesting medication. Many of you guys have probably heard of Suboxone. So I'll start by explaining what Suboxone is. And sometimes I find myself using the two interchangeably. They're not the same, but if used correctly, they should be the same. So what Suboxone is buprenorphine plus naloxone, plus that Narcan. But the naloxone, the Narcan, is only activated if somebody misuses their Suboxone prescription, if they inject it. If it's taken sublingually or in the GI tract, the naloxone is inactivated. And so it's essentially Suboxone, and that, if taken correctly, it should just be buprenorphine. So what is buprenorphine? Buprenorphine is a really interesting medication because it's a partial opioid agonist, meaning it binds to the opioid receptors, but it only partially activates them. And this allows this ceiling effect, because you have all your opioid receptors bound, but they're not all fully activated, makes it a very, very useful drug for treating opioid use disorder. It prevents respiratory depression because it is of this partial agonist effect. And it also, prevents people having altered mental status of euphoria, particularly those with opioid use disorder. It has a very high affinity for the opioid receptor. And so it will bind your receptors more readily than pretty much all other opioids and block them from having any action. But one thing that's kind of tricky about that is also displaces other opioids. So we'll talk about precipitated withdrawal a little bit in future slides, but The idea is that if you have, let's say you use and then you take your buprenorphine, it can actually knock off the opioids off of your receptor and precipitate a withdrawal. And that feature makes it tricky to start. And so that's why we'll talk about how to start buprenorphine in a little bit. It is pretty long acting. Its half-life is 24 to 36 hours, not as long as methadone, but much more long acting than other short-acting opioids. And then it's convenient because of its incredible safety profile. You don't have to go to clinic every day and be monitored while you take it. You can take it home. Buprenorphine can be prescribed by any clinician if they have something called an X waiver. And in January, I believe, or maybe it was February of this year, the Biden administration got rid of the requirement to get an 8-hour training before receiving an X waiver, but they didn't get rid of the requirement that you need to like submit for an X waiver, which is essentially just putting your information in and then getting X in front of your DEA license. But just the process of having to do that obviously creates a barrier for many people. So buprenorphine saves lives. It's an incredible medication when taken. So I thought this was an interesting slide. It kind of looks at the number needed to treat for common things we do: aspirin for primary prevention, warfarin for DVT, something closer to home in pediatrics, therapeutic hypothermia for severe hypoxic ischemic encephalopathy. And you can see the NNC of buprenorphine is less than 3 to save a life. Downsides. So I've talked about all the amazing parts of buprenorphine. Probably, the downsides, there are side effects. They're rare. They're less severe than other opioids. People report trouble sleeping, nausea, headaches, constipation, things that you see with opioids. If you mix with alcohol or benzos, especially people who inject Suboxone or buprenorphine, there's been some case reports of overdoses. So mixing with other substances can be dangerous. We've talked about this already, but some treatment programs, it's part of the criminal justice system, some NA groups, they don't support buprenorphine use because it's an opioid. There's a lot of stigma around that. And this is especially true throughout the country. But even here in California, we've come across this. Because it's an opioid, it has to be tapered slowly to avoid withdrawal. And then it's tricky to start due to the risk of the precipitated withdrawal. So how well does it work? Buprenorphine in adolescents, there's been 3 RCTs, and basically treatment retention it's okay. It's generally lower than adults, although the adult population also has a challenge with treatment retention. Remember, opioid use disorder is a chronic, relapsing and remitting chronic disease. So about 25 to 40% of patients are still in treatment at 6 months and 9 to 17% at 1 year, depending on what study you look at. And actually, fourth leave treatment after a week. But this is very similar to our experience at Valley. About 50% will come back to treatment within a year. So, but what's really important about buprenorphine is that all-cause mortality is significantly lower when patients are on buprenorphine. So I like to tell our nurses and our hospitalists, even if a patient leaves the hospital and uses again that week, for that short time that the buprenorphine is in their system, we've saved their life. How long are people on it? I get that question a lot from both patients and staff. The evidence really shows that teens, like adults, do better the longer they're on buprenorphine. And most experts that I've talked to consider 6 months to be minimum and really no maximum length of treatment. There's a lot of neurobiological, neurochemical changes that happen with opioid use disorder, and it does take some time. People have cited to me 2 years at least to sort of restructure the brain back and decrease the risk of relapse. So I just, this piece is just highlighting there continues to be just so much stigma when it comes to addiction. And I like to remind our group that we should treat substance use disorder like any other chronic disease. We should treat emergencies and crises promptly. We should expect periods of relapse and recovery. And some patients are going to be more apt to follow treatment plans than others. And we still treat them all when they seek care. So like DKA, we have patients that come in, at least to Valley, 4, 5, 6 times a year in DKA, and we treat them all right away and try to work with them wherever they're at. And then a huge best practice is to improve access. So hopefully you've had a chance to read our Surgeon General's quote, just reminding people that this is a chronic disease and we need to treat it with urgency, skill, and compassion. Speaking of access, I thought this was pretty striking. In the 90s, in the 80s and 90s, France had a heroin problem. And what they did was they made it so any doctor could prescribe buprenorphine without any licensing or training. And with the change in policy, all of a sudden, the majority of buprenorphine prescribers became primary care physicians rather than specialists or psychiatrists, addiction medicine specialists or psychiatrists. And suddenly about 10 times as many patients began receiving treatment, and half of the country's heroin users were being treated. And the overdose death rate within 4 years had declined by 79%. So really striking. And speaking of access, where now can you start buprenorphine? So technically, you could start buprenorphine in an outpatient clinic and at home. And basically, I'll pause for a second because in a few slides, I'm going to talk about our protocol. But the key thing with starting buprenorphine, because of that risk I described of precipitated withdrawal, is you have to wait until somebody is in at least mild withdrawal to start, because you don't want to precipitate a withdrawal. So that's usually about 10 to 12 hours after fentanyl and longer after other opioids. And so what's challenging about it is that it takes time, because what you're going to do is you're going to start when they're in withdrawal and then give them doses in small increments until you capture their withdrawal. So it's tricky to do this because it takes time, it takes hours. Outpatient clinics, there are outpatient clinics that will do this for adults. It's been very hard. And I think I've talked to some of the Packard folks about trying to get patients that have been admitted for overdose into outpatient care. It's very hard to find outpatient physicians who will do this for adolescents. So the outpatient clinic is great. It's convenient. But it's not widely available, both because there's not a lot of providers out there, even for adults, and because of that X waiver requirement. Most primary care physicians don't have it. And to be able to do it in an outpatient clinic, a patient would need to come when they're withdrawing, and patients might not actually be ready during normal clinical hours. Some providers will do it at home. They'll actually prescribe and give people instructions at home. That is obviously more convenient, but there aren't a lot of providers that will do that. I haven't found any that will do that for adolescents. So because of the challenges with outpatient and at home, there's been a huge movement to get Suboxone or buprenorphine inductions. Starting buprenorphine is called an induction in the emergency department. And there's a program called California Bridge that is close to bringing this to every emergency department in California. The idea is that people can come in withdrawal, they can be monitored. You don't need to be an X-waiver physician to prescribe buprenorphine in the ED. So EDs can just do it. It's obviously 24/7, 365. But what we found, and part of the reason why we're doing this work, is that it's not working well for teens, the emergency department model, because a teen will come into the emergency department and say, I need help. And they'll say, okay, well, you're not in withdrawal. Come back in 5 hours because your last use was 2 hours ago. And then we never see the teen again. And so it's actually our emergency department that asked us, hey, could you guys start admitting these patients because we don't feel like we're helping them sufficiently? And so inpatient, I have a question mark because this is what we've started to do, but it's not something that I've seen in the literature or heard of elsewhere, where we're voluntarily admitting patients for buprenorphine induction. But what's nice about it is that our patients can come prior to withdrawal. They can show up and then wait 8 hours in the hospital, wait 10 hours until they're ready. They can come anytime. Our hospitalists don't need an X-waiver to prescribe in the hospital, although they've all become X-waiver to prescribe outpatient when they go home. What's nice about it is they're away from their home environment during the most acute phase of withdrawal, and we can support them and give them time to connect to outpatient services. So with that introduction and kind of explaining the landscape of where we are, I'll talk a little bit or a lot now about our inpatient buprenorphine induction program for adolescents. Now it's been exactly 1 year since our first pilot patient. It was January 9th, 2021. So I have a year of experience to talk about. So this is our workflow, and don't worry, I know it's small and hard to read, but I am going to break it down. Basically, what we do now is that we'll get referrals from one of 4 places. The emergency providers, and I've already discussed, they feel like the emergency department is not always the right place for teens, so they'll refer to us. Outpatient providers, and we haven't had many pediatricians refer to us, but we have special therapists, substance use treatment therapists in our county, and they're seeing a lot of these patients. They're the vast majority of our referrals come from therapists. Juvenile detention. So before we started admitting patients, patients would go to juvenile hall and they would have to go through their withdrawal experience without any help or medications. But now they'll be transferred for juvenile hall to us, and then we transfer back to juvenile hall once they're stable, and then self-refer. So the word has gotten out, and people have friends, and so patients will call me or our nurse program coordinator to come in. Once I was on the phone with a patient and he said, hold on one second. And then he handed me to his friend, and his friend said, can I come in? And then they said, hold on one second. And then he handed me to a different friend, and we got all three of them in. So all of them will call the hospitals for admission, whether through the transfer center, depending on, which location. The process is a little bit different, but they'll call the hospitals just like for a regular admission. And all 9 of our hospitalists are trained in what to do. Who's eligible? So the hospitalist will decide, is the patient less than 21? Do they meet DSM-5 criteria for OUD? And I put the criteria up to the right. And do they want to stop using opioids? This is a voluntary program. They don't have to come in. So this is our protocol. What's been really great about doing this in a teaching hospital like Valley is that the residents are involved. And so when I was a resident, actually before 2020, I honestly didn't know what buprenorphine was. But now our residents are admitting these patients, taking care of these patients, seeing them through their induction, and learning about opioid use disorder and how to treat it through the process, which is really exciting. And so basically, once they come in, the residents, there's an order set that they'll order. And then the order set basically takes us through the protocol. Our nurses will perform something called the Clinical Opiate Withdrawal Scale, or COWS. And I'm going to go to the next slide and then come back to this slide just to talk about COWS for a moment. So COWS, the COWS scale is just basically a scale. It's out of 48, and it objectively measures someone's withdrawal. It looks at pulse, sweating, yawning, pupil size, et cetera, and kind of does some calculations to figure out where someone is in withdrawal. If the number is 5 or more, it's considered to be mild withdrawal. And we treat patients when their COWS are 8 or more. So we don't let them get to very uncomfortable levels, like extremely uncomfortable levels of withdrawal. But again, we want them to be in some withdrawal before starting because of that concern for precipitated withdrawal. And so the nurse will perform a COWS, and then if the COWS is greater than 8, our protocol has them administer 8 milligrams of buprenorphine and then reassess in 1 hour. If the COWS is still 8, we'll give another dose, and so on. The total dose they get in that day becomes their dose on day 2. So we're trying to figure out how much people need. We used to have, and if anybody is really experienced with this on this Zoom in this presentation, they may ask me, why are you guys using 8 milligrams? Most protocols use 4 milligrams. We started with a 4 milligram protocol, but we ended up going to 8 milligrams because all of our patients are fentanyl use disorder. And our experience has been that 4 milligrams takes too long. It's not enough. It's been not enough at all for these patients. And it prolongs their feeling of discomfort so that when they relapse, they're scared to come back in. We've had so much more success since we made the dose 8 milligrams. And that's what emergency departments are doing throughout the state. We also give adjunctive medications, so clonidine and hydroxyzine PRN for anxiety, and then trazodone to help sleep, because during that early acute phase of withdrawal, those things can be quite severe. Talked about COWS. I'll talk a little bit. I want to bring opioid withdrawal to life for those of you who hadn't seen it, and I hadn't seen it until this year. Probably the best story we had a patient come in, very severe fentanyl use disorder. I think he reported using fentanyl basically every hour of his waking life for the last 2 years. And he was pretty nervous to come in, but we kind of instructed him like we do, don't use the night before, and then come in, and then we can sort of get you started as soon as we can. But he came in severe withdrawal. His COWS when he came in was 28, and sweat was literally dripping down his arm so much that it looked like rain was coming down on the floor. Every hair on his arm was kind of like sticking up. He was pale and freezing cold and sort of like writhing. And we got him tucked in. He put as many blankets on him as he possibly could and kept asking the nurse for more blankets. And it was interesting because we always like to teach interns or residents, sick versus not sick. And though, technically it's rare for opioid withdrawal to cause severe illness or death, the patient looked sick. There's no other way of putting it. You were concerned about them. And that's what they described. They described feeling that they are dying or going to die. Patients that have come in like less extreme, what tends to happen is they'll come in before they're in withdrawal, and they feel they're like nice and polite and super grateful. And I say this like almost all of our patients have sort of had the same thing happen. They're nice and polite and great. And then all of a sudden they're getting closer to their withdrawal, that stage 1, and they're starting to feel really anxious. And most of them will literally pace the room. Like we see them all just going back and forth in the room, and they become very irritable and almost rude to staff. And then once they get their buprenorphine in and they're kind of captured, they apologize and feel really grateful. And it's something that we've seen again and again. So I wanted to kind of share. So let's talk about discharge. So the discharge process is obviously quite important because we got people on this medication, but that's not the whole story. And so what we make sure we do with all patients is that we schedule them with our outpatient medication-assisted treatment provider. This is a child psychiatrist who's getting addiction medicine training, who sees all of our patients. We also schedule them with their substance use therapist. As I said, most of them come in already having a therapist, but if they don't, we get them one, and we make sure that they have appointments scheduled. Or some of our patients will actually go straight to a residential facility or a rehab from the hospital. We have a relapse prevention worksheet that goes through triggers and things about what they're going to do in certain situations that we go through with them. Either our psychologist or our residents will do that. And then we have parent and caregiver buprenorphine teaching. We talk about how the best practices, what buprenorphine is, how long they'll be on it, what the contraindications are. And then we make sure that they have their prescriptions for buprenorphine, Narcan, and the adjunctive medications delivered to their bedside before they go. And they'll either go home or to a residential facility. And that's really up to them in combination with their therapist. The typical length of stay is about 24 hours. We've done less, we've done more. And then the outpatient management is with our Dr. Nasrin Bashiri. She will see our new and unstable patients up to once a week, and the stable patients monthly. She'll titrate their buprenorphine dose based on if they're having side effects, she'll go down. If they're having cravings, she'll go up. And then she'll wean off slowly once it's time to wean. So there's not a lot of good literature on the best practices for weaning, but most people will just wean down very slowly. And then every other Friday, we meet as a group, the inpatient team, the outpatient team, and all of the therapists. And we literally go through each of our patients and that are active and figure out what do they need, how can we best support them, where do we need to get them in? And that's been quite useful as well. So I'll talk to you a little bit about our patients. We had what we call 7 pilot patients. So from January to May, we started doing this, but we really didn't start studying it till May 1st and collecting data on the patients. So we have 16 official patients, 7 pilot patients, but actually 26 admissions because like I kind of was alluding to, patients come back. So patients will relapse and they'll come back to us, part of that chronic relapsing remitting disease process that we've talked about. About half of our patients have been under 18 and half have been 18 to 21, which is actually significant because the older patients have more resources available to them in terms of rehabilitation facilities and otherwise. We have about 69% male and about 56% Hispanic or Latino. And 100% of our patients have fentanyl use disorder. So we haven't seen any heroin, we haven't seen any prescription pills. And, you know, people will talk a lot about how, you know, having wisdom teeth extraction. I know there's been, I think Alan wrote a paper or other surgeries that lead to opioid use disorder. And I haven't talked a lot about the origins of that for us, because the story with most of our patients is that they started using marijuana and cocaine and ecstasy, and they basically tried everything. And then they found themselves with on fentanyl, and that's become their substance of choice. Interestingly, they all say that they do perks. So perks, shorthand for Percocet. And what they think is Percocet is pure fentanyl. They don't have any Tylenol in their system when they come in. So if you hear teens talking about perks or Percocets, FYI, that's pure fentanyl in our county. And interestingly, our patients, you know, they often come in on the evenings or on weekends. So the clinic-based models that some places are able to have, it wouldn't really be meeting the needs of at least our patient population, because they have a hard time coming in exactly during what would be standard clinic hours. So we're actually studying this by looking, formally at 2-week, 6-month, and 1-year follow-up. But I decided to just look at January 7th, 2022, like just, where are our patients? How are they doing? And about 44% of them are currently in recovery. 19% of them are currently relapsed, and about 38% are currently lost to follow-up. So maybe slightly better than what we've seen in the literature, but that's kind of where we are. I wanted to bring to life a few of our patients. I'll start with probably our, most straightforward and shining example of a patient, and then kind of give a more realistic, typical perspective. So the patient, we had a 18-year-old girl. She came in last summer, and she had been using fentanyl about 5 times a day for the last year and a half. She wasn't able to do school anymore. She was having trouble in her relationships, and she really wanted to stop. But every time she tried to stop, she was so scared of withdrawal that she just couldn't go through it. So when she found out she tried to find an outpatient doctor. She couldn't find, but when she found out we had an inpatient program, she was really excited. She came in super nervous. We got her through the withdrawal. She was so excited that like the nurses were clapping and cheering for her when she got through it. And basically every day since her hospitalization, she has taken her buprenorphine, and she has not relapsed. She's done incredibly well. She actually went to community college and changed her major to nursing because of our program, and is just, doing incredibly well. And I wish I could say that was all of our patients, but probably maybe this is a little bit of an extreme example, but probably a more typical example is the other patient I want to talk about. He's a 16-year-old boy who had been using fentanyl, every hour to 2 hours a day for the last 2 or 3 years. And he, at one point, his father had taken him to Fresno or out of county to a house and kind of locked him there so he didn't have access to buying, to try to get him to quit. And so he had gone through withdrawal without any support. And the experience for him was so scary and so uncomfortable that he had this huge fear of withdrawal. And so he actually had 3 pre-admissions where he said he was coming and he didn't show up. And then he had 4 full admissions where he would come to the hospital, but then as soon as he was getting close to withdrawal, he would leave. And it was on his 5th admission that he brought his aunt, who was a huge support for him, to help him get through it. And he got through induction, only to leave and relapse again within the next week. That happened a second time. He was then picked up. He then ended up having to go to custody. He was in juvenile hall, and he came to us from juvenile hall, went through induction, then went back to juvenile hall, and then was transferred out of county to a rehab program that was like a 6-month-long rehab program where he still is today. Our outpatient provider and therapist had talked to him regularly, and he's doing very, very well. He's finishing up high school. He's, hasn't used. They describe him as really a different person, but he hasn't had that challenge of coming back home and coming back into his triggering environment, which is coming up in the spring. So our challenges, retention and treatment is obviously a challenge. This is a challenge not just for us. This is a challenge for the adult providers. It's a challenge nationwide. We're trying all sorts of different things. We're doing more education. We're trying to get groups. We're trying to get more wraparound services for these kids to help with that. A huge challenge is the stigma of buprenorphine. There's still so much stigma, and it's not just with some treatment programs, but it's also with patients and their families. We have a lot of kids that are like, when can I get off of this? When can I get off of this? I don't want to just trade one opioid for another. And we remind them that you're not going to be on this forever, but this is allowing you to go to school. This is allowing you to go to work. And, it really takes time to recover from all the fentanyl that you've been doing for so long. But they get a lot of input from the outside that, they've just substituted one opioid for another, which is a huge challenge. And then sort of devastatingly, parental consent has been a challenge. You do need parental consent for outpatient buprenorphine. So inpatient, you can get it without parental consent in the ED as well, but not in the outpatient side. Unlike, birth control, it's not exempt from that. And this is just quite sad. We have a patient who, a 17-year-old girl who's super motivated and has a very disorganized family. And whenever she would come to the outpatient provider to get refills, her parent wouldn't show up. She couldn't get her parent to come. and sign the consent paperwork. So there's a lot of advocacy that we're trying to do through California Bridge and otherwise to try to change that law so that teens can consent to their own treatment, but we're not quite there. Our next step. So we really want there to be an alternative rehabilitation facility in the county or in the Bay Area that takes kids with Medi-Cal. There's only one. It's a Christian rehabilitation facility, which is not appropriate for all of our patients. And there's just not a lot of options. If you have private insurance, there's some great outdoor facilities that have horseback riding and, fishing and all these programs. But for our Medi-Cal patients, there really isn't a lot out there. And we've been talking about maybe trying to get the counties to cost share and create a really great evidence-based rehabilitation facility for teens in the Bay Area, but obviously that's a long ways away. More quickly or sooner, we'll try to have groups for teens, and we're next month we're going to pilot groups for teens and groups for parents. The parents have really been asking for groups to help support them through this process, and then a more intensive outpatient treatment program. Right now, the options are to go to rehab or to go back outpatient with like weekly meetings with our outpatient medication provider, and then 2 to 3 times a week with your therapist. But we're trying to kind of buff up a IOP program for them. Our team, so our inpatient group is me, and many of you guys know Dr. Monica Stemley. The nurse, we have 3 amazing nurses who have been incredibly helpful in making this work on the inpatient side. And then our outpatient team, as I've mentioned, is the child psychiatrist, Dr. Nasrin Bashiri, our substance use clinicians. And actually, we've just recruited a family medicine doctor who works in the homeless clinic at Valley to see some of our patients, which has been really great because many of them are homeless, and the homeless clinic has really great wraparound services. I have to thank our inpatient hospitalists and nurses because they've learned a new skill. They've taken it on enthusiastically. They have been incredible in helping treat these kids. And then our funding, which is from the California Residency Program Collaborative Grant. So how to get involved? I hope that I've made a good plug for access, that we need more access. And you can get your X waiver if you're interested at something called the Provider Clinical Support System, PCSS website. I have the website right here, but you can always email me if you can't quickly type that out. And the X waiver now, as I said, it's just filling out a form basically, and then you get your X waiver. You don't have to do any training, but I imagine that some people might want to do training. And luckily there's still buprenorphine focused course, a pediatric focused course. It's an 8-hour course on the website that can help you learn how to prescribe buprenorphine. So in summary, what I hope you got out of this was that our opioid epidemic is only worsening, unfortunately, and now we're in the 3rd wave, which has been dominated by fentanyl. That buprenorphine is a long-acting partial mu opioid receptor agonist, and it has been shown to treat opioid use disorder and save lives. That you can send your patients with opioid use disorder to our program, and hopefully that you'll want to get your X waiver and help improve access for teens struggling with opioid use disorder. That's all I have. Any questions?
Dr. Trope, thank you so much for such a fabulous presentation. There's a lot of comments just, again, thanking you and telling you how impressive this program is and what a wonderful way to advocate for a really high-risk patient population. There are a few questions that John G and I can go through, so I'll tackle the first one. How much of an issue are other illnesses in addicted adolescents? For women who are at risk of conceiving, is contraception support also provided?
I got the second part of the question. Can you say the first part one more time?
How much of an issue are other illnesses in addicted adolescents?
Great. So in our experience, we haven't had many comorbidities at all. We had one patient with latent TB, interestingly, but nothing else. But the question about contraception is an excellent one. We have had 3 of our female patients actually get pregnant during this year. One of them was a very wanted pregnancy. The other 2 weren't. And we've been trying to implement, having contraceptive counseling as part of the admission. And although that can be a little bit, not all patients want that, and obviously that needs to be voluntary. But yes, that's a great question. That has been something that's come up.
And then Lee, a couple just more logistical questions. One of them was talking about, this patient's sometimes looking very ill. And are these patients universally cared for in the ward at Valley, or are they ever admitted to the ICU? Or is there special training that the nurses need to go through to be able to handle this?
They are on the ward, and really they don't need any special training other than knowing how to administer buprenorphine. And these patients get better very quickly once they get the buprenorphine. And so we just remind the nurse that this is what withdrawal looks like. And now that we've had so many patients come through, most of them kind of have seen it and know that the treatment for it is giving buprenorphine. These patients stabilize quite quickly.
Wonderful, thank you. And then there's a question about what type of buprenorphine do you use? Is it the extended release? And then another question about, are these patients weaned off slowly, or is it maintenance that is preferred?
So that's a good question. So because it's been so great to have nurses as part of this, because they've been like teaching. So we initially used the buprenorphine tabs, and they take like apparently 30 to 45 minutes to dissolve. So we've recently switched to the sublingual Suboxone inpatient, and those take much less time to dissolve. So that's kind of what we're using right now. And then the second part of the question was, so our patients then they leave on maintenance, and our outpatient provider will wean them, and she won't wean anyone until 6 months. So they're on it, unless there's extenuating, but so far she hasn't weaned off anyone until 6 months. So the idea is that, like, the study after study has shown that the quicker people are off buprenorphine, the higher risk of relapse. And so we're keeping patients on it until they're at a much more stable place, which takes months, if not years.
All right, another logistical question. Are these patients eligible for CCS? This could be very helpful for long-term outpatient management until they turn 21.
That's such an interesting question. I don't know. I'm going to take that back with me to our group. Right now, we haven't been doing CCS, but I honestly hadn't thought of that. Thank you for the suggestion.
And Lee, there's a couple of questions about upstream and prevention and identifying the causes first, and followed by rapid regression in less than a month, as you had mentioned on one of your slides, as well as the question is, what is the role of prescribers in this opioid epidemic?
It's such a good question. I have to say, like, I need to focus and learn more about prevention. There's a lot of literature to suggest, as I hinted at, that having exposure to prescription opioids in adolescence can predispose people to opioid use disorder. And as I said in my presentation, that just is not our experience. This disease process, it's my expertise. My expertise is in none of this, but my expertise is certainly not in prevention. And so I don't want to say things that I don't really know a lot about, but I'll just add that, of course, exposure to opioids is a problem, but the problem is broader than that. It's opioids are binding to our endogenous receptors that we have, in our bodies for connection, love, euphoria. And, we have a crisis in a lot of communities in this country of, lack of opportunity, lack of connection, lack of possibility. And of course, if you can take something that really provides what we all need, it can be highly, what's the word I'm looking for? Highly sought after, and so the roots of this problem, I think that they're very much related, as I mentioned in my presentation, to how many opioids we have in our country, but also related to a crisis of opportunity, possibility, and connection. And then the specifics on the data, I'll leave to somebody with more expertise.
All right, Dr. Trope, someone here is thanking you for such a great talk, and also wondering, in the past, the criminalization of opioid addiction was a really major deterrent for adolescents to seek treatment. How have you provided similar education to the law enforcement agencies?
That's such a good question. So what's interesting to me about all of this is that you can educate, in my experience of this, the same is true with our nurses and some of our providers at Valley. You can educate and tell people as much as you want, but until there's something that people feel like they can do, the culture feels like, it's harder to change. And what I found is that now that the nurses and the providers and even the parole officers, right? They have a place to send someone that they feel like they can help them. The orientation towards the patients has changed dramatically. People aren't, speaking about them in the same way because they feel like they can help. And so I'll just like leave it with that. We've tried to do education, we've tried to talk, and I don't think it's really stuck until there was an actual option available. And it's been really interesting to notice that.
Great, thank you. Another question is, what percentage of patients combine this treatment with regular attendance at Narcotics Anonymous or other 12-step programs?
So far, none. We give them the resources for Narcotics Anonymous, but for whatever reason, our teens aren't going. I think there's a lot of adults there and it's a little bit of a different environment. That's why we're trying to start teen focused groups. And we've had tons of teens feel excited about like our groups with our hospital. A lot of them know each other also. So I'm really hopeful they're going to start out in February. I'm really hopeful that they'll be successful, but we have NA and we give them that resource, but it's not well utilized.
And Lee, there's a lot of questions about how ambulatory providers can get more involved here and how we can maybe take on a French model of tackling this all. Is anything from your experience on what we can do as outpatient providers to approach this problem?
Anyone can do, it's not that hard. It really isn't. You just need to get some training and your X waiver, and then you can be part of this solution. And honestly, I've had some calls with inpatient physicians at Packard who are trying to find someone who can see these patients. The outpatient's been really tough. Honestly, if you are an outpatient provider and you are interested in this and you want to make this like one of the things that you do for people, you will have patients that will be sent your way. The key is what I would recommend is, in that last slide I showed how to get the X waiver, and on that same PCSS website, there's a course focused on pediatrics, focused on adolescents for buprenorphine. So to educate yourself, and then you can reach out to me. I can connect you. There's mentors. I've had mentorship to learn how to do this with some folks in Boston who've been doing this for a long time. And there's mentors. It's just really nice to have a mentor who knows what they're doing, who's been doing this for a while, that you can bounce ideas off as you're getting started. So for an added layer, just feel free, if you're one of those people who's interested, message me and I can get you connected with some of the expertise around the country.
Okay. And then a question about substance use. And what do you do if a patient's using, say, methamphetamine, is also having issues there and is coming in? Is that a situation you've encountered so far?
So yeah, it's interesting. It's a good question. So I would say not all, but the vast majority of patients we've had are daily, nonstop marijuana users. And that is not a contraindication to Suboxone. I was worried because it's really not recommended to use buprenorphine Suboxone with alcohol. And I was thinking, that could be a huge problem, but it's been interesting. We've had one patient out of all the patients we've seen that even uses alcohol at all. Alcohol just does not seem to be an interesting substance to our patient population. We haven't had any co-meth. Most of our patients, other than marijuana, are really they're focusing on marijuana and fentanyl. Those are like their two substances. And once in a while, we'll have some dabble in cocaine, and we do a lot of education about the real contraindications are benzos and alcohol. With cocaine and meth, there's been some concern that when you're on buprenorphine, you may not realize how much there may be like a decreased feeling of how much you're using in terms of cocaine and meth, and that can be quite dangerous. And so we do education on that, but we haven't come across meth. Interestingly, I also work in the well baby nursery and in the NICU. In our pregnant women, we have a little bit more co-occurrence meth and opioid use disorder, but it's not something that we're seeing as much in the teens.
Great. And then we'll have one more question here. So someone is wondering if you considered giving adolescent-oriented talks like at local schools or other programs to summarize this data for students?
No, I haven't really thought about that, but it's a really interesting suggestion. I think there's a lot more students out there or people out there struggling with opioid use disorder than we're seeing. And so getting the word out there is huge. And I didn't mention this, but our therapists that are sending us a lot of these kids, they're based at schools. And so they have a really nice eye into what's going on at those schools throughout San Jose. But it's a really interesting suggestion. I appreciate it.
Well, I want to be conscious of the time. It's now 9:01. Lee, this is an absolutely amazing presentation and outstanding work you're doing. It's so important and truly life-saving. A lot of the questions in the chat are just, how can we do this? How can we get these slides? How can we try to spread the word about what you're doing and maybe even do it ourselves? So I guess I would defer to Ingrid and you in terms of how we can coordinate distribution of some of this material.
Thank you so much, everyone, for your time. It's nice to be somewhat back at Stanford, even though it's virtual.
Wonderful. Thank you, everybody, for participating. And again, if there's any questions or any follow-up, please feel free to reach out through the email at the PEDS Grand Rounds. Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.